The following program, Live and Learn, is made possible by Aging Partners. Find out more on their website at agingpartners@lincoln.ne.gov.
I'm Sam Truax, and many of us older veterans are not aware of all of the services that are available to veterans. Today, my guest, Rick Ringline, the Lancaster County Veterans Service Officer, is here to tell us about some of those services available to veterans.
Have you ever wondered if you or someone you love may have a problem with drugs or alcohol? Today I'll be talking with retired drug and alcohol counselor Donna Wood, and she may have some answers for you.
Healing from the inside out. I'm Kristen Stowes. Please join my conversation with Dr. John Reed and learn the medical facts about wound care.
Dick Chapin started working for KFOR Radio in 1952. He's 92 years of age and living proof that it's never too late to live and learn. I'm Lita Powell-Drake. Stay tuned.
This and more on today's Live and Learn.
I'm Sam Truax, and today, recognizing Veterans Day on Live and Learn, we are going to have a guest, Rick Ringline, who's the Lancaster County Veterans Service Officer. Mr. Ringline, what does the County Veterans Service Office do?
Well, Sam, the County Veterans Service Office is required by state statute, and it's a county-funded agency. And what we do is we help veterans and their dependents become eligible and learn their eligibility for different state, county, and federal VA benefits, veterans benefits.
So actually your office really determines their eligibility and helps them with the applications for state and federal funds, or does the county actually distribute any funds to
We
them?
have a Lancaster County. All the counties have a county veterans aid fund. It's a budgeted part of our county budget. This year's budget for county veterans aid is a little over $14,000. We have a veterans service committee that oversees our office. That's made up of 5 wartime veterans, and they're the ones that provide the guidance how we use that fund.
Yeah, I see. Yes, that's right. Of the veterans services available, what services are most being applied for or requested through your office, do you suppose?
Throughout the whole age range of veterans, we see veterans as young as 18 years old that have just come back from basic training, all the way up to World War II veterans still. Compensation, which is service-connected disability, injuries that incurred in service or due to an exposure in service have caused disabilities. That's service-connected disability compensation. That's probably the thing we deal with the most as far as application numbers. And then also there's 2 programs for pension. There's non-service connected pension, that's for the veterans themselves. And then there's a survivor's pension, which is called death pension. And those are the 2 programs that we deal with on the federal side the most. There's some education benefits. We have several colleges and universities in Lincoln, and so that's more in tune with the younger veterans that are just being discharged under their GI Bill.
Yeah, and seeing the most asked questions, it looked like the pensions and care for their medical, and I don't have rent money type of requests are what you were getting a lot of, but you'd get home loan applications too, and as you say, it's GI Bill, schooling.
Right. A lot of it, to start, let's start from scratch. The first thing you really need to do is get your active duty discharge papers, and that's the Department of Defense Form 214.
Yep.
Depending on who you're working with, it could be somebody young or someone that served 70 years ago. They may have lost it. It may have been misplaced over the years. So that's the first thing a lot of times we have to do is access that DD 214 or some other discharge proof prior to that form. We have the ability to access those starting at the top from the National Archives in St. Louis. The state of Nebraska has a lot of discharge papers on file, the Nebraska Department of Veterans Affairs. Our county clerk has a lot of on file, and then the ones we have in our office are shared with the county clerk. It's a protected document, so not anyone can access that document.
And so you basically tell the vets, you got to go get that paper, or can you really get them?
We'll help them.
And help
We'll
them?
help. If they
out.
have it, they bring it with them when
Yeah.
that we have that initial visit.
Yeah.
But if they don't have it, that's one of the things we need to get.
My DD 214 is pretty old. It's kind of haggard by this time, but I could bring it if.
Yeah.
See, I wear my veteran's hat in case you have a really good benefit. You'll know I'm going to come after you.
I'm going to make you come over and see us.
There you go. Well, again, the process. What process is it that the veterans can do to actually get you to start helping them?
Okay. Our office is over in Trabert Hall. The actual street address is 2202 South 11th. That's on the south side of 11th and South Street, where you would access our office off of South Street, either from the east or the west on South Street. We're right next door to Lancaster Manor Nursing Home. Our building is the old dormitory when St. Elizabeth's Hospital was down there, and we're the dormitory for the nursing students years ago. The hospital's gone, but the dormitory is still there. We get a lot of referrals either through the VA clinic out on South 70th Street, other agencies, county agencies, state agencies. A lot of ours is word of mouth, that someone has said, these folks helped me, they helped my folks, they helped my mother, they helped my father, you should go down and see them.
Yeah, so then that's basically how they initiate. They come down and see you. Even the veterans facility out on South 70th Street actually refers
Right.
it to you, because you're primarily the helper that starts it for all state
Right.
and federal stuff,
Yeah.
are you?
That,
If
for
they
our
go-
county, yep.
If they directly go to the VA, for example, they're just going to tell them go to the county office,
Well,
right?
a lot of times they will,
Yeah.
just because we have more time to deal with them.
I see.
And
Yeah.
And so like with the medical clinic, if you have a service-connected disability, it helps your eligibility for certain services and the co-pays. And so we work real close with them together, and vice versa too.
The VA facilities are very, very, they have a long queue of waiting people. It took about a year and a half for them to determine my eligibility, for example. And so
Yeah,
they should have told me to come to
they're-
you.
They're trying to get better, but no, like you say, we appreciate the help of other outside agencies referring people to us. And like you say,
Well-
our biggest compliment is when a veteran tells another veteran, come see these people, they will help you.
Well, case is, it's not just you down in that office either, so you can maybe handle quite a few people.
Right. We have a staff of 4. We're all veterans. We're 50-50 male, female, and so we're kind of unique in the county that I think our numbers are quite equal that way.
Yep.
Everyone that works with us, we're a team.
See?
We have
That's-
Elgin Hunt. He's been with us for years. We have Karen Pullen and Rebecca Hellbush and myself. And our office, we kind of have banker hours, but we can work around that. And so if someone needs to come in late or come in early, we work for veterans. Without veterans, we have no job. So
Well, actually, the county commissioner, Roma Amundsen, is an
Right, correct.
ex-military,
Yeah.
see, so
Yeah.
she should appreciate your work more than some of the other county officers have in the past.
Yeah.
So, of all the concerns about governance, what is your governance?
Okay, the Veterans Service Committee is made up of 5 individuals that are wartime veterans. They're nominated from the different veterans organizations in the county, and then on a 5-year rotating basis, someone is appointed then by the county board to be on the Veterans Service
I
Committee.
see.
They're all volunteers, they're not
The
paid.
county board actually assigns them, that committee to be your
Yeah, and it's
overseers.
strictly volunteer.
Yep.
And we have a great bunch. Some of them, the guys have been on, I've worked here almost 20 years, and some of the guys have been on the committee for
Yeah,
20 years.
I did want you to bring that up, that you've been there 20 years, so you've encountered most of the situations that the veterans who come to you are
but
going to.
but it's a learning process too, Sam. I mean, we're accredited service officers, so we have to go to accreditation training. We have to keep our accreditation up. The different national service organizations require that accreditation to make sure we know the changes that are coming in. And it's serious. You learn something new every day.
Well, we will make sure we show on the screen where the people have to go, but you repeat that again.
It's
2202,
2202
yeah.
South 11th, and the street address really doesn't make much sense as far as if you plug that into a GPS or some type of Google Maps, you're going to come to a cul-de-sac in the back of the building. And so 11th and South, on the south side of 11th and South, it's
Are there other
four-story.
county offices there? Is that a county
Child
building?
support is in there. There's some state offices
I
in
see,
there.
state offices.
Parole, probation.
I see. Well, again, the veterans who are older sometimes are a little hesitant to come for help, you know, because they had a more independent spirit maybe than the current veterans do. So I want you to encourage them to come and see you if they really
Right.
need the help, because
Right.
you do have recommendations on medications, pensions, and perhaps death benefits. I don't know.
Right. That's one of the things that we deal with a lot, unfortunately, is survivors' benefits.
Yeah, the survivors. Yeah, that would be.
Then going along that same lines, there's headstones and markers that are provided free for the veterans. Under Nebraska state statute, wartime veterans' graves need to be marked with a permanent metal marker, and then that's up to the counties to provide those markers. And we have 2 different sizes in the counties that show your veteran service.
I see.
And
Yeah,
so
there you go.
a lot of times we'll deal with families that didn't even know they were entitled to benefits.
Yes, that's
And
it. So, and a lot of families don't even know that they can come to you too after the veteran's gone. So I'm glad that at least some of them are talking to each other enough to know you're there.
And again, the funeral homes are real good about referrals.
Oh yeah, that would be a
like
good
that.
reference too, wouldn't
So-
it? Yes, yes, yes.
But no, it's a rewarding business. I mean, you're helping somebody every day, and you can't help everybody. We try our best. If we can't help somebody, we try and give them a referral to an agency that possibly can.
Well, during November, we recognize the veterans with the Veterans Day holiday, which many local businesses support by giving free meals and other benefits to the veterans. And it's good to know that Lancaster County recognizes our veterans by providing the services of your office. And I hope our viewers who need assistance at your office will come and see you. Many past veterans have kept their difficulties to themselves, but it has been determined that with PTSD and other strains, part of the military service, keeping it to ourselves is not a very healthy option, really.
That's correct.
And do some of those guys with PTSD come and say, I don't feel good, what should I do about it? Or they go to the VA and then the VA says, we'll let you determine they're eligible.
When we talk with people, we'll discuss anything that may be bothering them that could be related back to the service, be it cold weather injuries from being in Korea like yourself.
Yeah, there you go.
But the whole gauntlet of things. I wanted to mention our office hours. We're there Monday through Friday from 8:30 to noon, and then from 1 to 4. Like you say, if we need to make an adjustment for an individual, we can do that. We don't take appointments. We take walk-ins. We do have the 3 service officers there. We really can't schedule like doctors try to schedule 20-minute appointments, because some things we do take 5 minutes and some things take all afternoon.
Yes.
And so,
Well, I would like to thank our guest, Rick Ringline. He is the Lancaster County Veteran Service Officer, and I'd like to thank him for telling us about the county's Veterans Program. And remember, it's never too late to live and learn.
Hello, my name's Tom White, and my guest today is Donna Wood. Now, Donna is a retired drug and alcohol counselor. She worked at the Independence Center here in Lincoln from 1980 to 1991, and she's also worked at the Lincoln Council of Alcoholism and Drugs. Welcome, Donna. Glad you're here.
Thanks, Tom.
Hi. So, I guess the first question I want to ask is, how would someone know if they are an alcoholic or an addict, if they might have a problem with alcohol or drugs?
Well, I think the best thing that I've known of is the 20 questions that Alcoholics Anonymous put out. If you go through those questions and then they give you an answer sheet, if you've answered to 1 or 3 of those questions, you are probably alcoholic.
Mm-hmm.
The other thing that usually comes about is there's a member of a family or an employer that's telling them that they've they're having too many sick days, or they're hungover, or they're having reports of poor workmanship. So family and employers are usually a pretty good source.
Good indicators.
Yes.
Good people to help you with
Yes.
that. I see that you have those questions there in front of you. What would be
I do.
Maybe a couple of them just as examples?
Okay, one of them is, do you lose time from work due to drinking? Or is drinking making your home life unhappy? Do you drink because you're shy with other people? Is drinking affecting your reputation? Have you ever felt remorse after drinking? Does your drinking make you careless of your family's welfare? Has your ambition decreased since drinking? Do you crave a drink in the morning? Does drinking cause you to have difficulty sleeping? Is drinking jeopardizing your job or business? And do you drink to escape from worries or trouble? Do you drink alone? And has your physician ever treated you for drinking? Those are not all of them, but it says if you've answered yes to any of the questions, there's a definite warning that you may be alcoholic. But if you've answered yes to any two, the chances are that you are an alcoholic.
I guess that would also apply. A lot of those would apply to someone who's having problems with drug addiction or possible drug addiction, whether it was prescription medication or
Right.
or illegal drugs.
Right. I'm not as familiar with prescription drugs or you know, other drugs, but yes, there's.
So do you remember any clients that discovered that they had a problem? Any of the clients that you had when you were counseling that had discovered late in their life that they had a problem?
Not many. And I was thinking of that usually there were more women than men that were older when they came into treatment. And usually they were also addictive to prescription meds. And so a combination of the two usually got them there. I don't know. I had I did an intervention. I was an intervention specialist when I was working there, and I know one time I was practicing with a family so that they could intervene on their son and and they had their other sibling, the other children there, and the father kept making excuses for the one we were going to intervene on. And I finally said, you know, we're not going to be able to do this if you keep making excuses for him. We have to tell him about his worth, and you keep making excuses for that. So the second time we met, he said, I think I might have a drinking problem. I think that's probably why I'm doing this.
Oh, so that's why he was rationalizing and justifying his own behavior.
Right.
Because it was also his son's behavior.
Right.
Yeah.
And you know, the outcomes, I happen to know the outcome of this one. I don't know the outcomes of a lot of them, but the outcome of this was that the father got into treatment and is in a 12-step program now and is still sober. However, his son never did quite make it and died about 6 years ago.
Oh dear.
A young man.
So, yeah, denial seems to be a huge part of the problem. You hear that often when you hear people talking about
So much is denial.
Yeah.
They just cannot see for themselves. I mean, I've seen people in the hospital who were there and it wasn't their first time in the hospital because their body was just giving out from the drinking, but they still were denying that alcohol was the problem.
So what would you do or say to someone who suspects that a friend or a family member might have a problem? How would you, is there anything that they can do to help? Or is there anything, what can they do?
There's several things that they can do, or a couple things that they can do. The one thing that I like is to refer them to Al-Anon. Al-Anon's a 12-step program for families of alcoholics or addicts. And that seems to give them some relief from the turmoil that they've been in. And it also, in the end, will get that person, the person they're concerned about, into treatment or get into some kind of treatment. Also, intervention is a great tool for getting a person into treatment, and that's where everybody in the family is brought in together, and they make lists of what they think this person how that person is so valuable to their life. People think that they should get together and they should tell this alcoholic or drug addict all the terrible things that he's done or he or she has done. And that's not the purpose of intervention, because that's going to drive the person further and further into their addiction. People think that they should tell them what they're doing and make them see that. But the best interventions that I've ever seen is where this family had their lists all made out, and they said, this is why we think, this is why we miss you. You're not a member of our family anymore. You know, like we used to laugh and joke, and we used to tell stories, and we don't get that from you anymore, or I don't get that from you anymore. This is why I love you. This is what your worth is to me. That can get a person to look at themselves faster than anything else.
Oh, that's interesting.
And I know I had a family that had intervened on this young boy, and he was only 22. And when I saw him at my office after they had done the intervention, he was crying, and I said, it's tough to look at yourself, isn't it? And to make this big step. And he said, he kind of looked at me and he said, no, he said, I just can't get over how much my family thinks of me and how much they love me. And that's why he said, I'd want to do anything to save that. So I think intervention is the wonderful thing. I called Independence Center, and they have a good intervention staff, and they have a couple nurses too that go into the hospital, and they do interventions on people in the hospital.
In the hospital. Yeah, because the destructive quality of, I mean, how many, not only, you all often hear about the liver or the pancreas or those things where people have problems with those, but there are a lot of health issues associated with the drugs and alcohol abuse.
That's true.
Other than those, and I think is. So tell me about some of the. Do you have any other stories about the interventions or any that?
There's a lot of them. I don't know if there's a lot of employers that have come to Independence Center. And one of them was the athletic staff at UNL. They brought a lot of their people or their students, their staff to intervention, and we had interventions on them. I had an intervention on with an employer, and he brought his person in, and his family was there, and we did an intervention on him, and he chose to lose his job rather than go into treatment.
Wow.
Yes,
Yeah,
that's heartbreaking when you see them take off and they don't want any part of intervention. I mean, they don't want any part of it, treatment.
So what do you suggest for the friends, employers, or family if somebody does not want the help, if they refuse the help?
I think then the family just needs to get in touch with Al-Anon. For me, I think that's a good solution, because at least they're going to start getting healthy mentally and physically and emotionally. and they're not going to be sucked into that disease of the addict or drug addict.
That was something else I had heard, is that they refer to it sometimes as a family disease, because
That's for sure.
yeah.
Because everybody starts reacting around the person that's drinking or using. And they're doing things that they usually wouldn't do otherwise.
There are some other phrases that I had heard about that, enabling or rescuing, is that seems to be a problem when a parent or a friend continually bails somebody out of their jams. Is that also something that you would run into with the...
A lot, yes. They're usually taking over their responsibilities, or they're getting them to work, or they're getting them a different job, or they're, I mean, this is for usually children of that are younger, but even a spouse will try to take over for the if the husband has gotten into trouble at work or legal trouble, the spouse will try to take over for them, and they don't have a life of their own anymore. They're just responding to whatever the alcoholic or addict is doing. They're not enjoying life anymore.
Just all because of the...
All because of the addict or the one that's drinking and using.
So just to kind of wrap this up, as far as the most important thing that somebody who thinks that they have a problem can do for themselves, if they're really concerned that it's gotten out of hand.
Well, one thing they can do is you can look in the paper and find out where there's an Al-Anon meeting or where there's an AA meeting. I think AA is a very good remedy for addicts and alcoholics, or any addiction. I think a 12-step program, there's so many available, and that's usually listed in your newspaper. Yeah, I know of a lot of people that have probably gone to Alcoholics Anonymous to remedy their situation, and they've been sober for many years.
Mm-hmm. So the treatment centers, maybe a combination of the treatments.
The treatment center can also be so very helpful for family interventions. I think that's and they recommend that they go to a 12-step program also.
Oh, okay.
But yes, a treatment center, and there's quite a few in Lincoln.
Oh, that's good.
Yeah.
It's nice to have those resources available. In fact, we're listing those resources as part of this interview, I think. We're listing quite a few of those.
Good.
So, well, I want to thank you so much, Donna, for being my guest today. And I've been speaking with Donna Wood, who is a retired drug and alcohol counselor. My name is Tom White, and remember, it is never too late to live and learn.
What does Medicare cover? How can I afford to keep living in my home? When I need help with house and yard work, who can I turn to? Why am I so tired? Am I eating right? Should I exercise? Where can I go for answers to my questions about aging?
Aging Partners is the place to call when you have questions on aging. Our experts are here to help you with unbiased answers for you or your loved ones. Aging Partners, we're only a phone call away.
Wound care, a subject we do not give much thought until we need it. I welcome retired General Surgeon Dr. John Reed, who will explain why this subject is of such great medical importance. Dr. Reed, welcome to Live and Learn.
Well, I appreciate the opportunity, Kristen.
Wonderful to have you here. You retired in 2006 after 31 years in your general surgery practice, with no real plans to get right back into the medical world, as I recall. But just after 3 weeks of retirement, you were asked to join the Wound Care Center.
Yes.
Could you please tell us where that Wound Care Center was located at that time and how it has grown since then?
Well, it initially started at Bryan Hospital and had been transferred to another facility at 7441 O Street.
Okay.
It's called an outreach clinic of St. Elizabeth, but it's the Wound Care Center, WCC we call it. And it's been in existence at that location, I think now, maybe 18 years or more.
Oh, wow. And I believe you have other clinics located as well?
I do other clinics. I've been asked to do clinics at nursing homes, and one another large aspect of my practice is at Madonna.
Okay.
And they have a great number of patients there, and it was very difficult for them to transfer their patients to the wound clinic or to be seen elsewhere because they're so very ill and very fragile. So they asked me to start seeing the patients at the bedside, and that's what I do.
I see. That makes a lot of sense. Going back to the year 2006, what was the need that required a separate medical facility to address wound care?
Well, wound care was so fragmented. In this way, we've consolidated it at the clinic, and it is really gives us an opportunity to concentrate only on wounds where other physicians or their practices are oriented to other areas. But also, we have the expertise with nursing primarily. The doctors that are there are multiple physicians. On each day there's a different physician. And so with this being so concentrated, and we have concentrated all this knowledge and expertise in one location, it really makes an advantage to the patient.
Yes, I can understand how that would be. Wound care can require the coordination of several different specialties, isn't that true?
Orthopedic surgeons, dermatologists, internal medicine, infectious disease. The orthopedic surgeon is very integral to the practice. Plastic surgeons are utilized, and so it's a wide range of areas of medical expertise, all involved and concentrated in one location. We do have on-site plastic surgeons. We have orthopedic surgeons, and so this is really a great value to have that.
And your goal, simply stated, is to heal non-healing wounds.
Right, yeah. Wounds that last, say, a month or 6 weeks, a non-healing wound becomes a chronic wound, and it will go on, can lead to infection, limb loss, and foot ulcers, for instance. And so I think it's always our goal to get the wound to heal and put the patient back to being back to their own home environment or their work environment, as the case may be.
Certainly, certainly. Just to establish the need for our viewers, how many patients combining all of your clinics do you see in 1 month?
Do I see? Personally? This week I will have seen 48.
Okay.
Times 4.
That's a big number.
A big number, yeah. It'll be, somewhere in the high hundreds.
Okay, okay.
Sometimes I get more than that, but that's usual, like, for instance, this week, as I said.
Let's examine this subject by looking at a diagram of what normal skin looks like while you briefly explain the healing process.
Okay. Well, this is normal skin, and we consider it 2 layers. The top layer that's in the red, that's called the epidermis. The very thin layer on the top, more white, is the epidermis. It consists of 4 or 5 layers, depending on the location. The one underneath with the blue and the red and the hair follicles, that's called the dermis. And that's where all the nerves, blood vessels, sweat glands, oil glands, everything is located in this layer, nerves as well. The top layer, our epidermis, is relatively inert. It's our armor coat, though, that protects us from the outside environment. Now, you can take off the epidermis, and very rapidly new skin will regrow, because the epidermis, the dermis, the lower layer, has that ability. You can take off the dermis, that's the lower layer that's in red or pink. You can take that off and you'll still regrow new skin. But when you get down to the fat, then that's a different story. And when you take off the 2 top layers, the epidermis and the dermis, that's called a full thickness wound. And then below that is a wound that's deeper and more serious and more ominous.
And you said that healing is promoted from the inside out.
That's correct.
So you have to recreate the wound, basically take it down to the base layer.
That's right. When you first see a wound, it's unless it's not red and healthy. This is a wound in the wound clinic. Always give new employees, new nurses that with us on wound rounds, explain that when you cut yourself with a clean glass in the sink, you'll heal up in a week or no more than 10 days. That wound is a clean wound, it heals properly, but a chronic wound will not do that, and it can linger on and on. So what we want to do is that chronic wound, we want it to recreate it back to an acute wound. An acute wound will heal. So patients will tell me, well, it looks perfectly all right. Well, it's not all right. What we want to do is recreate that back, and that's the main thing we want to do to promote wound healing. But there's other factors that interfere.
Sure, certainly. So when seeing a new patient in your office, what steps do you go through to assess the treatment plan for this patient? And I believe we have some steps to put on screen while you briefly talk about those.
The patients are first come into the wound clinic and they're new to us, so we obtain a detailed history. How long it's been there, what caused it, have you ever had it before, any family history, cancer history. Medications are very important, so we have a medication list, and we review that very thoroughly because certain medications are definite impediments to wound healing. Patient's physical examination, circulation is very important as far as wound healing. Many of our patients are diabetic and they do not have good circulation because of the diabetes. Just having diabetes alone is an impediment to healing. But also, diabetes affects the nerves. They may have numb feet. They may have very painful feet. Diabetic nerve pain, it's called. We then, to ascertain that, the nurses, this is all on intake now. They'll ascertain the circulation. If they can't feel the pulses, we use what we call a Doppler to determine that. And then also, they use, I call it a cat's whisker, but that's not an appropriate name. But regardless, they can test the patient's sensation as far as that's concerned, and you'd be surprised how many patients really do not have sensation in their feet, and that just leads to more mischief in the diabetic.
So what physical wound indications should tell someone that they really should be seeking medical attention?
Well, I think, as I said, the longevity of the wound, or how the length of the wound you had, might have been from trauma. Diabetics don't feel they have an ulcer, and all of a sudden they've got moisture or something on their sock. They notice, and they'll come to you. But if it lasts 4 weeks, has gotten worse, more pain, signs and symptoms of infection, maybe they carry a low-grade fever even, redness around the wound. This is all an indication you should have that attended to. But I think basically the thing is this wound just won't heal. They've used every lotion and potion, and they've done everything they can think of, and maybe they've been to their doctor and they've had a course of antibiotics and that's failed, and so then you end up. And
it's really important to get that wound addressed. What are the basic ways that a wound can be treated then?
Oh, we, this day and age, one of the things, when I was in practice, for instance, they did not have good orthotics. That's offloading devices. We have good offloading devices, particularly foot ulcers. We have many more ways to of dressings we use for the patient that are much more effective and do not really set the wound back, shall we say, as far as the healing process is concerned. Certain things you can use on it. For instance, if patients say, well, I've been using peroxide for the last 2 weeks and it hasn't gotten any better. Well, it's gotten worse because peroxide doesn't care whether it's good tissue or bad tissue. It'll destroy all those tissues. Soaking's bad. Bathing's bad because you're just reintroducing the same germs. Some of the medicines they put on the wound they're allergic to. And so we have the advantage of much better dressings, much better ways. We routinely, if the wound is not healthy, we do what we call debridement of the wound. There's many different kinds of debridement, but usually in our clinic even at Madonna or the other facilities I go to, we use surgical debridement, which is instruments to recreate that wound again, recreate it back to an acute wound.
So of all the different kinds of wounds there are, what is the most difficult to treat?
Oh, I'd say diabetic foot ulcers, by far and away.
Is that mainly due to the circulation?
With diabetic circulation, location, offloading. It's very, very difficult.
Can you briefly address the topic of diet? What is the, I'm sure good nutrition is
good nutrition,
paramount.
yes. Diet. People think of diet, well, you're gonna lose weight. Well, what we look at is wound healing. We look at the actual protein nutrition that patient has. Utmost important.
Protein is the most important?
It's one of the keystones of wound healing you have to address. There are other factors. Infection is one, and you have to address the infection. The diabetic, you want your diabetic under good control. The other factors that we look at, we've talked about offloading. The patient that's in bed develops what we used to call a bed sore, a decubitus ulcer. Offloading all of that is very important.
Okay.
And so you have to consider all these factors in, make everything optimal you can, then you can expect wound healing or progressive wound healing.
One advancement you mentioned that you have seen in wound care is the vacuum-assisted closure system. Could you please briefly explain that? Because this seems to be a big advancement.
This is the greatest thing.
Okay.
I sound like I'm advertising for it, but I'm not. It's a device. You have a wound. It's usually it's a large and deep wound.
Okay.
And we used to put dressings. When I was, I've been a lot of things in my day, but I was an orderly at Bryan Hospital way back, and I remember treating those ulcers with tea bags, Maalox, sugar, everything, a heat lamp, everything you can think of. Well, we did everything wrong then. But anyway, it seals the wound, keeps it from becoming infected from outside sources. Any drainage is captured so it doesn't sit there and bathe the wound. Its main object is, by its very name, vacuum-assisted closure. The wound is under vacuum, it's sealed, and there's a sponge in there. And if you make the sponge a little bit smaller than the actual wound and put it on suction, it'll draw the wound to itself. And so it helps that way. But it also promotes this foundation of healing tissue called granulation tissue, promotes those. And that's what the healing process is built on. It's a foundation.
So it definitely prevents reinfection.
Oh, absolutely.
Yes,
no doubt about that.
Which is big, right?
Yeah,
Exactly. I know the Wound Care Center sponsors a conference. Could you talk a little bit about that?
Every other year, yes, they do. Every other year, they have a conference. Consists of various health providers, maybe nurse practitioners or PAs, a lot of nurses that deal with wounds. I think the last one that I've given some of the I don't know if lectures or talks, but anyway, I've given one, and there were 400 people there.
Really?
And they have to close it off at that because they could have many, many more. It's that popular. But it's really brings those that are dealing with the patient firsthand, the nurse or care provider, firsthand knowledge. Day one might be how to address wounds of new wound care products that we have available to us. The second day is a didactic, more to speak, the more speeches.
So you are really carrying the Wound Care Center across Nebraska in this manner, which is that's just fabulous.
Right. Plus, the Wound Care Center has outreach clinics in smaller towns in southeast Nebraska.
Well, I definitely know that Nebraska is better in wound care because of the Wound Care Center.
I think so.
Yes, and we thank you for your tremendous work at the Wound Care Center. And we thank you for being here with us today, Dr. Reed.
As I said, I appreciate the opportunity. It's a little known subject. When I tell patients what I do, or people I see that I know, what do you do? And I tell them, I do wound care, and you get this blank look.
Well, it's very important, and we thank you for it.
Thank you again.
And as always, please remember, it's never too late to live and learn.
KFOR Radio went on the air in 1923, and what you're looking at now is a Philco floor model that dates to 1923. Do any of you remember having that in your home? Hi, I'm Lita Powell Drake, and welcome to Live and Learn. Today, we're going to go back to the wonderful years of KFOR radio. Dick Chapin has been a part of KFOR radio since 1953.
Correct.
And was so happy that he is still working at age 92. He's an incredible man, and we're going to learn a lot from him today. Welcome to Live and Learn. How did you find that job back there in 1953?
Well, I was working at the Lincoln Chamber, and Arch Bailey was the manager at that time, and he hired a new man to do membership, and I was mad about that because I was doing it plus other things. And well, he told me, Dick, you know, sales is where you make the money.
Yeah.
And that very week, George X. Smith, who worked for Jim Stewart, saw me on the street and said, Dick, I'd like to talk to you. So I went and talked to him. He offered me a job in sales. I was going to make as much money as I was at KFOR or at the Chamber. So I was delighted to go back to tell Arch I was leaving and pursuing a sales career. So that's how I started.
Well, now, you're at 92. You're still working. You are a media broker. What is that?
Well, buying and selling radio stations. I've never dabbled in the television. But I'd been in radio for so long, from 53 to 86 when Stewart sold the company, and I became president of the national radio and television industry, so I knew a lot of people, a lot of owners. And so when he sold the station and I got out, I was 62 and I thought I was too young to retire, so I decided to pursue this career in brokerage, and it's been very good and very interesting.
Been very, very good to you.
Very, very good, yes. It's been very, very good
Well,
to me.
at 92, the fact that you're still working is just wonderful. I think about our wonderful old days of radio and the programs that I listened to, you know, as a child.
Sure.
And let's go back now to those thrilling days of yesteryear. In particular, the ones that I remember, of course, would happen to be the Lone Ranger.
Oh, yeah, the Lone Ranger.
Return with us now to those thrilling days of yesteryear. From out of the past come the thundering hoofbeats of the great horse Silver. The Lone Ranger rides again. Get 'em up, Kemosabe. is that?
Oh, yeah, we carried that on KFOR. And I think I remember that Robert's Dairy was a sponsor of it. So.
And of course, one program that was on forever was Paul Harvey.
Well, Paul Harvey was an unusual man, and I think he was the greatest thing that ABC ever had, and I got to know him personally. He came to Lincoln 2 or 3 times and did his program from the KFOR studios. He was a great guy, and I had him speak at a National Broadcasters meeting once, and he called me and asked if what he'd written was going to be apropos, and I said, no, we're having trouble with the FCC, maybe we could talk about that, and he did.
Well, that made me think about Roger Larson, because Roger also did those little talk pieces daily.
Oh, yeah, and that's the way I see it, is what Roger called. Well, I'd instituted a mandatory deal in the stations that you had to do editorials, because I thought editorials were, but I wanted to be local. I didn't think our guys should be talking about something in the Far East when they don't know anything about the Far East.
Yeah.
But they ought to talk about things locally. And so after Roger got out of radio, or not got out, but when he got out of KFOR, he developed that on his own and continued and did a very good job.
He really did. Another favorite program from radio was Gangbusters. Look at all the guns.
I never knew that, but I knew Gangbusters. I was a young buck at the time, and they used to come on, and there was a gal that I went to school with, and her dad was the head of Fairmont Dairy, I think, and we'd all go to her house and listen to Gangbusters, and he'd give us all an ice cream bar, so it was a big event.
Well, Stewart Broadcasting bought KFOR Television in 1952. Moving from radio into television, what happened, Dick?
Well, I was not with him when he first started. I was there shortly after it went on the air. But he applied for Channel 10 and got allocated Channel 10. The thing that we did not have was we did not have a network. And trying to run a television station without a network was very difficult. And there was no no tape then. There was no taping.
Everything live.
It was everything live, or what they call kinescope, where they take a picture through the camera that they're doing now. But that was always grainy. And I remember we would buy Liberace and run Liberace. Kenny Greenwood was at KFOR in those days, and he started a program that's still on the air. It's the longest continuous television show, I think, in the U.S., called Backyard Farmer. And George Round from the University of Nebraska would bring over people, and they started up. We had one camera and one studio, and of course, we'd run up and down from set to set, you know. So it was an interesting deal. We finally decided that we had to increase the power. We were going to have to go color, and it was going to be a big expenditure. And I think Jim decided at that point that he'd do it. Channel 12 was allocated to Lincoln. Ed O'Shea and some other people had that channel, and they wanted out. So Mr. Fetzer from Kalamazoo, Michigan, bought Channel 12, went to the Federal Communications Commission and told them that he would give them all the equipment and stuff to set up an educational television station. He was very bright because that forever put a commercial station out of business.
That's exactly right.
And so the university took that over, and Mr. Fetzer bought it, built that big tower out by Beaver Crossing.
1,000 feet tall.
Which was the highest in the country at the time, and did a wonderful job with it. But I hated to see the television shut down, but I knew it was doomed. So that's how he got Channel 10.
Yep, and KFOR radio is still there.
The thing I remember about it is when he sold it, Jim sold everything in the station. I mean, he sold the desk, the telephones, everything, and so I had to start a radio station from scratch.
Well, some of the memorable people, of course, in the morning show at KFOR radio with Dick Perry and Bill Wood. They were on for a long time.
Well, prior to Dick and Bill, when I went there was a boy named Bob Johnson. I think some of the older people in Lincoln
I remember Bob, yeah.
And Bob did his show from his home at the breakfast table. And we also had Bill McDonald, who had worked for KFAB, a renowned farm broadcaster, and he lived out by Walton in a place called Blackbird Road, and he did his show from out there, so it was quite interesting. But the morning show was important. If you didn't own the morning, chances are you weren't going to do very well.
And of course, well, succeeding Dick and Bill, of course, and Kathy Blythe.
And
Scott Young.
And Scott Young, and they were tremendous. And I think those two won at least 2 Crystal Awards, which are the best programming awards in the industry.
Well, of what are you most proud, Dick Chapin?
Well, I think community things that we did. The Operation Santa Claus wasn't mine. It was developed by 2 gentlemen that preceded us. And it started in 1949. I came aboard in 53, but I recognized how big this program could be, and it's still continuing.
It's still going. That's
still
what
going,
I like, yeah.
And called Operation Santa Claus, and they've done a lot of wonderful things for needy children in the community, and so I think that's something that they can be proud of. We started what we call the Lucky Day Calendar, which really isn't a community thing, but it became that way because it continued for 40-some years. I think they just discontinued it last year, but I'm not sure.
Well, in fact, we do actually have a copy of an old one, and it's got some of the wonderful pictures of the history of KFOR.
Each year there was a theme to it about the community, and we had some wonderful pictures in it, and this one happened to be pretty historical. But that I'm very proud of that because we invented it and made it what it is.
Well, Stewart sold everything back in 1986.
Yeah,
but you got another job.
Well, actually, what happened is the people that were buying all of the stations wanted me to stay with the station, and so I agreed to do it. I had to sign a contract. But I only stayed with them for a year. They said they wouldn't change anything, like everybody that buys a new business says, but they started right away. So I lasted a year and then said goodbye.
Well, in those days, in the early days of radio, you could only own 1 AM station and 1 FM station.
In the community, that's
now,
right.
The sky is the limit. You don't even know what you're listening to out there. What What happened? What's happened?
Well, the FCC had what they called an 80-90 docket and decided to create 900 new FM stations. Well, that came out, and then people started crying about that and said this was unfair. They ought to be able to own more stations in a community, and then the FCC, in their wisdom to correct it, allowed what is happening today. You know, in Lincoln there are owners that own 6 stations, so you know you can't do justice to 6 stations. So I don't think it's nearly as good as it used to be. I think the one owner of AM, FM in the market, because those people are going to try their darndest to do community things that are important. They have to if they're going to win the race. Now you have programming off the clouds, and there's no people in the station, there's no live voices on some of the stations. So I don't think it's good for the community.
It's hard to distinguish which program, you know, to listen to, you know, as the listener. I mean, there's just so much out there.
It's just crowded, very crowded.
Dick, you have won about every award going in broadcasting. Of course, the Nebraska Broadcasters Award, the National Association of Broadcasters Award, the Hall of Fame, the Broadcast Pioneers.
I got a lot of them, yeah.
Well, now, but you were telling me about when you were ahead, Harold Anderson from Omaha was also right up there with you.
Same year, which is kind of interesting, that 2 boys from Nebraska would wind up having 2 national organizations. I handled up the radio TV, and he handled up the American Press Association. So Harold was a very capable guy.
Yeah. Well, you ain't no slouch either, kiddo. Dick Chapin, may you live long and prosper.
Thank you very much.
I've got the Vulcan salute. It's hard to do. Can you do your fingers like that?
No.
It's hard. I can't do it so much in my right hand, but the Vulcan salute, may you live long and prosper. And you've done exactly that, live long and prosper.
Thank you very much.
And this man is living proof that it's never too late to live and learn.